Pediatrics in 2018, and also has presented various papers in national, international fora, and also a lot of presentation in all fora. Sir, with this, I hand over the session to you, sir, and please, sir.
Okay, thank you. Thank you for the introduction and inviting me for being the chairperson of this program of attention deficit hyperactivity disorder. And as mentioned, October is a month of ADHD awareness. And definitely nowadays, I think all the parents are having the know-how of about ADHD, because almost all newspapers and the medical common medical magazines, because in Kerala itself, almost all newspapers have their own health magazines also. And I have written articles in almost all these magazines in a yearly basis. So I think the awareness of ADHD is definitely there, but still there is a gap between the management understanding and its role of adult problems, because we know that a child will be carrying this problem to his adolescence and to adulthood. So we have Dr. Sunil Godbole to give the first lecture on clinical practice guideline, diagnosis, screeners, and tests. Because we know that for a definitive diagnosis and for initiating treatment, a guideline-based diagnosis is better, because being a neurodevelopmental disorder, there may be differences between various or differences and similarities between various other disorders like opposition defiant behavior or a temper tantrum, the juvenile delinquency, etc. So Dr. Sunil Godbole is the developmental pediatrician, director, Chiranjeevi Child Diet and Development Center, Pune, head of the Department of Small Steps, Morris Autism and Child Development Center, Deenanath Mangeshkar Hospital and Research Center, Pune. So he'll be dealing with the clinical practice guideline, diagnosis, screeners, and tests. So hope Dr. Sunil Godbole is ready for his presentation. Dr. Sunil, can you start your presentation? Start sharing.
You, sir. Thank you, sir. Thanks for a very a good introduction of mine, and I thank you for the good words you have talked about me. And person like Dr. Kunju saying such good words, it's always a motivating factor. Thanks the Kepler group for calling me for this event. I think we will. We will start directly go with the clinical practice guidelines and diagnosis, screening, and test. Today, I'm going to focus not on the typical ADHD signs and symptoms, which everybody knows. I'm going to talk how we have to approach it. So the approach is important. So this is how typically a child with ADHD comes to us. So the parent as well as the teacher both are at their wits when such child is to be managed by these people, and that is a very tough time for everybody how to work on that. And that is where the story of ADHD begins. Nowadays, since the children are becoming very hyperactive since the early age, overactive. So this particular picture is not only seen at after 6 years, it is also before that also. So now let's just touch the definition to open up the topic. It is firstly to understand it's a neurodevelopmental or a neurological condition which involves two parts at one time, inattention on one side and hyperactivity and impulsivity, and which is most important line to understand is developmentally inconsistent with the age. So it directly hits on one particular point. So we need to know about the signs and symptoms of inattention, hyperactivity, impulsivity, part 1, and at the same time developmental age of the child, part 2. So these two things together, they are going to come with it. So we are aware that it is now increasing now. Yeah, IIP is quoting 11% of the children in India are facing this problem, while the male, unfortunately this time the males are more than females. The rest of the world now the females are going at, but here still the males are, the boys are more than the females. And interestingly, 1.2 in that in adult, this difference goes down, and the ratio remains the problem. And most important point, why to discuss? In any child development center, the 50% of all the developmental disorders, the first diagnosis that may come in picture is ADHD. Now, autism has also started competing with this diagnosis, but still, this is a very common diagnosis. So that is why we include. Now, when to screen? So when these two things come together, as a problem with attention, hyperactivity, impulsivity, and his behavior is impacting his performance at home as well as in the school and in social settings. So if a parent tells us or a teacher tells us that after these two things are coming together, the child is unable to perform well, even though he has got a capability, because he cannot focus, he cannot stay at one place, that is the time we should start screening this child. And at how to screen? So screening is something where the sensitivity high and the specificity may be low. So in a screening interview, it starts with an interview. That is very important to remember. Screening starts with interview. The NICE guidelines directly quote that it cannot be only filling up the forms and questionnaires. A detailed interview with the caregiver, and if the child is big enough, talking to the child as well as the parent. So first part is what are the basic complaints? Typical day recall. दिन भर में क्या होता है? What is happening over the day, and what challenges the child, and because of the child, the people around are facing in everyday life. This is going to be the important marker for understanding it. Then medical history, especially about sleep, thyroid issues, and substance abuse. I'm going to highlight this substance abuse right here only, especially a child who was not having ADHD and not having ADHD in childhood and started facing the problems like ADHD in adulthood. In adolescence, think that it may be a substance abuse, because they may manifest in the same way and a very different line of treatment is required. Family history of similar issues, especially is there a family history on the father's side, mother's side, because ADHD has genetic roots as well. What is the parenting style? It is only the permissive style or very much authoritative. The parents are on the helicopter parenting other. So we need to know this parenting style, because the management of ADHD is going to change or differ about that. Obviously very important. We are not here, I understand, as a developmental pediatrician we always say we are not here to label a child with a diagnosis of ADHD. For that, what we require, what are the strengths and weaknesses of the child? So there may be a ADHD child will be wonderful in sports, he may be wonderful in music, he may be wonderful in drawing. So there may be something else which the child is also. Those strengths we should be knowing, and that is very, very important. The classic example is of Michael Phelps. Michael Phelps is not a typical child with ADHD, but today he is not remembered for his ADHD. He is remembered for his 8 gold medals in one Olympic at a time, that to repeating it again and again. So he is remembered for that swimming championship. So that strength we should be finding out, because that is going to take the child on a very different level over the life. And then the knowledge, what the parents know, because nowadays the Google University has given a big information blast to the parents, so they know a lot. But what their knowledge is, what is the attitude towards the disease, and what are the practices they are following. So this interview should be the beginning before we label the child or we go for the screening tools. And most importantly, a friendly talk. In double quotes, I will say this friendly talk with the school teacher is very useful, because she is the one who is suffering day in and day out, and child's performance is not to the mark in the school because of his ADHD. So all these things become in the first screening interview, which may take at least an hour or at least 30 minutes, and we need to be giving that time to the parents. Then we always have to remember that we are doctors and we need to know some other things as well. Growth charts, height, weight, head circumference, very important, because along with this ADHD, is the child having malnutrition, because malnutrition adds to the problem. A classic sign of pallor, we are all aware that iron deficiency has a direct correlation with the irritability and overactivity in the children. So, and also with the cognitive capabilities of the child. So we need to know these things. Obviously, there are some neurocutaneous problems or issues, which is we have no time for the today, but dysmorphic features we need to looking for, and they are important in knowing this differential diagnosis of ADHD with a genetic perspective. Assessment of vision and hearing, because I have seen a case, or rather not a case, or multiple of times, that a child was doing very well and suddenly starts misbehaving, labeled as inattention. And what was the problem? He was unable to see what is happening on the board. So assessment of vision and hearing is critically important as a mandatory part before we go ahead and diagnose the child with ADHD. assessment of coordination skills. It may not be only ADHD because ADHD is associated finding comorbidities and complications. We should be aware of that. Observations for verbal or motor tics. The Tourette syndrome, the tic disorders are associated with ADHD in some way. So we have to find out those things. We have to really matter. Observation of the child's communication skills to rule out ASD. Now here is a combination, very interesting thing I just wanted to touch and go, that ADHD and ASD, are they mixed together? They can be called as a comorbidity as well, but ASD, autism spectrum disorder itself has multiple finding parts of ADHD-like behaviors. And we need to be really differentiating them carefully. So without labeling a child with one particular disease, watch for these two things. Most of the time, my personal observation, which is observation, that parents like to have a diagnosis of ADHD over autism. And then sometimes we misjudge it, and then the that improvement trajectory goes on a different scale. So these physical examination parts are equally important before going for a developmental part. Now let's have the DSM-5, the old age-old standard DSM-5 criteria. Just to know that DSM-4 to DSM-5, there is a migration. Previously, the age of onset has to be before 7 years, but nowadays they say no, it can be documented at a later age also. It can be less than 12 years. Number of symptoms, the group of 9 symptoms are there in inattention, and you should have at least 6 of them. While in adolescents, it need not be 6, it can be 5 as well. So, sorry, I think I'll go back. So that is one part. Hyperactivity and impulsivity, similar part, 6 of 9 on this group. In children, it remains the same, but adolescent more than 17 years and 18, it can be less. Previously, it was told as a types, but by typing, we are again developing the boundaries, while the ADHD presentation is a word accepted by the DSM-5. Along with that, one mandatory part is the symptoms must be persistent for more than 6 months. So these are all things which are important in diagnosing ADHD. And this is something simple. It doesn't require rocket science. And the next part to it is, along with all this inattention and hyperactivity, the second line to remember is impairment in more than 2 settings, either social or academic or occupational. What is occupational for children? Play. And obviously at home. No other extra tests are required when it comes to diagnosis of ADHD. Just to have a quick glance, as I decided today, we're just going to run through these lines because we need to talk more on the other things. Carelessness, difficulty in sustaining attention in activity, then doesn't listen. Typically, the mother, father, or the teacher say, "Ye mera sunta hi nahi." So that is, it is not behavior, it is ADHD part also. Not following through. So we give some instruction and we tell them, you get it from there. And instead of going there, he just leaves it in between. So he's not following the instruction properly. Can't organize. So you look at the child with ADHD, his study table, it's all mess. The child cannot find his pencil, his rubber, his eraser, and everything not in a place. So child is not organized. It's not only the academic, the study table, it's everywhere. It's clothes, again disorganized. His time management, again disorganized. So this is one thing which can be really found out. Easily distracted. थोड़ा एक काम कर रहा है, थोड़ा बाहर आवाज आ गया, he gets distracted. Avoid tasks requiring sustained mental effort. So थोड़ा ज्यादा एक काम करना है, ज्यादा पढ़ाई करना है, ज्यादा और कुछ जहाँ पे फोकस करके काम करना है, ये कितना करना है मैं नहीं करने चाहता. So जहाँ पे sustained mental effort लगता है, the child tend to forget. They lose important item. तो ये टिपिकल पेरेंट्स की कंप्लेंट रहती है, या हरदम कुछ ना कुछ स्कूल में छोड़ के आता है. कभी इरेजर जाता है, कोई पेन जाता है, कभी उसका खाने का टिफिन भूल जाता है. सो लूजिंग इंपॉर्टेंट आइटम्स इज अ क्लासिक थिंग. एंड फॉरगेटफुल इन डेली एक्टिविटीज. कुछ बताया रहता है, he doesn't come up with the thing, he just forgets what he was supposed to do. So all these things together, and out of 9 we should have 6 to call a inattention presentation. That is very important. So this 6, it's sometimes commonly seen, but we should not be labeling quickly. We should observe the child carefully. In hyperactivity impulsivity, again we have got 9 pointers to remember. In hyperactivity, typically child अपनी जगह पे हिलता रहता है, screaming and fidgeting. A classic decision to have. Can't stay seated. टीचर बोलती है वो अपनी जगह पे टिकता ही नहीं, उसको कुछ मोटर लगे जैसे वो घूमता रहता है. एंड रनिंग एंड क्लाइंबिंग एक्सेसरी, उसको मदर बोलती है कि इसको डर ही नहीं लगता, वो चांस मिला तो कहीं खिड़की पे चढ़ जाता है, चांस मिला तो कहीं पे भागता जाता है. दैट इज टिपिकल हाइपर एक्टिविटी चाइल्ड. कांट प्ले क्वाइटली. Now, this is very interesting to remember as compared to autism. ऑटिज्म के बच्चे कभी कभी बहुत शांति से सॉलिटरी प्ले करते रहते हैं, बट एडीएचडी के बच्चे शांति से बैठ ही नहीं सकते, खेलने के साथ आवाज चालू रहता है, झगड़े चालू रहते हैं, दे डोंट लाइक टू हैव दोज रूल्स टू बी फॉलोड, सो ये टिपिकली उनके बच्चों का रहता है, ऑलवेज ऑन द गो, ड्रिवन बाय मोटर, घूमते रहते हैं, कुछ ना कुछ उनको करने को चाहिए, दे कांट। इनकी और एक इंटरेस्टिंग पार्ट है, दे टॉक एक्सेसिवली। दिस समथिंग अगेन आई वांटेड टू कंपेयर विथ अ चाइल्ड विथ ओवर एक्टिविटी इन ऑटिज्म। वहां पे टॉक उतना एक्सेस नहीं रहता, एक्चुअली कम रहता है। सो यहाँ पे थोड़ा डिफरेंशिएशन में पैरेलली सिखाने बोलने की कोशिश कर रहा हूँ। सो दीज आर द क्लासिक फाइंडिंग्स फॉर हाइपर एक्टिविटी, एंड अलॉन्ग विद दैट फॉर इम्पल्सिविटी कांट वेट फॉर द टर्न। तो अपने स्लाइड पे खेलना है इन अ गार्डन, द चिल्ड्रन डोंट वांट टू वेट फॉर समबडी एल्स टू गो आउट, उसको बाजू में धक्का मार के आगे जाएगा, सो दे कांट वेट फॉर द टर्न। ब्लर्टिंग आउट आंसर, टीचर ने कुछ पूछा है, कुछ हाथ ऊपर करने की भी जरूरत नहीं, दे जस्ट ब्लर्ट इट आउट, एंड मिस्टेक भी हो जाती है, दैट्स अ टिपिकल इम्पल्सिव चाइल्ड। एंड बाकी दो लोग बोल रहे हैं, इनमें इंट्रूड करना, इंटरप्ट करना, ये इनकी खासियत रहती है, एंड ऑब्वियसली ये सब उनको सोशल एक्सेप्टेंस के लिए प्रॉब्लम आता है। सो दीज ऑल थिंग्स टुगेदर मेक द डायग्नोसिस ऑफ हाइपर एक्टिविटी एंड इम्पल्सिविटी। Now, just to look at it, so we have got inattention, hyperactivity, and impulsivity, and we have got a combinations of them. And instead of DSM-4, we used to describe in types. Now we talk in terms of presentation. So it can be a predominantly inattentive, predominantly hyperactive, impulsive. So it's a double combination, and then a combined type. And depending upon that, then we go ahead. Now ये अपने को diagnosis के लिए पता चला है. So they have got standardized tools, questionnaires for that, so that we don't miss a point. So that questionnaires are to be not only asked to the parent, but to the teachers as well. Then the interview should also be a structured clinical interview of the parents, behavioral observations at home and the school. So there are lots of, we'll be discussing about the test shortly, but these tests discuss about all these things in a very structured way. That is very, very important. And not to miss, please talk to the child. उसको भी अपने मम्मी पापा के बारे में कंप्लेंट करनी है. He has a lot of to tell about his parents, for his teachers. Just give a listening ear to the child. इसका फायदा डायग्नोसिस में कम होने वाला है, प्रोग्नोसिस उसको हेल्प करने में ज्यादा होने वाला है. सो उसका अपने पेरेंट के साथ रिलेशन कैसा है, पेरेंट चाइल्ड अटैचमेंट कैसे है, ये अपने को पता होना चाहिए अलोंग विथ द डायग्नोसिस ऑफ ADHD. तो हमने पहले क्या किया, we had a suspicion raise, then we went for screening, then we came for diagnostic criteria. For that, now we are thinking of an interview. So it takes time. We require a developmental pediatrician to work upon it, and now you come with the questionnaires. Can general pediatrician work on it? Definitely. So there are easily available tools, but we need a practice. So DSM-5 ADHD criteria, and based on that, the Incline tool is developed in India, which is a wonderful tool. Indianized tool, a standardized, which can be very well managed by any good pediatrician with that developmental inclination. He can work out on this part. Vanderbilt assessment scale is another easily available tool, free to download. It has got the parent questionnaire, the teacher questionnaire, very well organized questionnaires, and they come with I personally like this tool over all other parts. Then childhood behavior rating, say to CBC, that behavior part can be managed. Corners 3 is another very research-based tool used very commonly abroad. The only problem is it is not freely available, and it needs to be licensed and take training and all that. The Snap 4 tool is also another questionnaire. It all go to the same lines. But along with either of the two, I prefer the first two, especially less than 5 years kid, less than 6 years kid. The DSM-5 ADHD criteria can be used above 4 years of age. Because even though these tests may not be standardized for less than 6 years, the DSM-5 criteria remains the same for the above 6 years child and below, say, to above 4 years. There is a research on that part, so we can use that. Vanderbilt is preferably used above 6 years, so because Vanderbilt ADHD assessment scale not only diagnoses ADHD, it takes care of the oppositional defined disorder, it takes care of the conduct disorders, it takes care of anxieties also. So it is a broader perspective, but for a broader scale, it has to be the age more than 6 years, which is a better way. So, but remember, and we have to tell this to the parents with an underline below that, assessments are not for labeling. The assessments are to plan and enable the parents and child to succeed. Because ADHD is one of the developmental disorder. You work properly on the disease, this problem doesn't remain as a problem for the child. The child can continue to live very successfully irrespective of ADHD. That is very important to remember. Do we need investigations? Actually, no. So no medical screen or brain imaging technique is required. यहाँ पे I respect the neurologist over here, but we don't require, unless we have got some suspicion, we don't require EEG, MRI, CT scan, or any hi-fi investigation for this kid. But there are some areas, if you find a child having signs of iron deficiency, it's a good idea to get hemogram and serum iron status. If the child is having signs of hypothyroidism, it is not going to be hyperactive child. A hypothyroid child will be a dull child, but you will have inattention part. So child having that part, get to thyroid function test. But surprisingly, rarely seen, but hyperthyroidism presents like ADHD. So we have to be very careful with this. Now this blood level usually comes from the literature from abroad. But yes, we need to think about this chronic lead exposure as one of the cause of hyperactivity and inattention. Research MRI brain, yes. If the institute is working on that, what they observed that on MRI in ADHD, there are findings suggesting a decreased volume of brain, especially the prefrontal cortex. I always say that atamaji satakli, because that is the controlling area where we need to stimulate by methylphenidate, basal ganglia, cerebrum. So you find decreased volume of the brain. But is it going to change the management of the child? Unfortunately, not. So I'll use those resources, that economy in a resource deprived country like that. I'll prefer to use those resources on better therapies and all that for the child. Functional MRI can be useful again as a research tool in if we're thinking of a hypoactivation of again right inferior frontal cortex. So these investigations are not mandatory. You have to select them apart according to the history of what you're finding. We may think about there are some other areas where we need to rule out diagnosis of ADHD with something else. So a gifted child, very high, good high intelligence, very sharp. Problem kya aata hai? He can't continue with the studies which is for his standard of age. He always thinks faster. Now kya hone wala hai? Ye bore hone wala hai. And in spite the child may not be ADHD, being gifted, he may be a problem child, and that problem child can mimic ADHD, and we have to rule it out. ADHD is nowadays taken as one of the part of learning disability. So academic or perceptual testing, psychologist by the psychologist, learning difficulty ke liye, all there are different tests which we don't waste time for the day. We have to think of that. If ADHD is associated with seizures and Tourette syndrome, at that time it is a must to have a pediatric neurologist in the picture. Getting EEG, 24-hour EEG, MRI, everything is required if you are having the associated neurological conditions. And if the child is having behavioral or emotional problem caused by anxiety, depression, ADHD and depression is another association we should remember. And that time we require the psychosocial history, personality testing, behavioral analysis, everything can be used, as we have to find out that extra part for ADHD. Now we should be also remembering the comorbidities of ADHD, and then diagnosis becomes complete. So here we need to remember ADHD and learning difficulty. In 50% cases, they go hand in hand. Oppositional defiant disorder and ADHD, another association. Anxiety and ADHD. The children are anxious because they can't control themselves. They want to do better, but they can't. That's their problem. Conduct disorders are commonly seen in children with ADHD, so we need to remember that. Habits, I was discussing about tics, but other habits also are commonly associated with ADHD. And mood disorders are sometimes seen with ADHD. But along with that, we need to remember about the differential diagnosis also. These are the comorbidities. Comorbidities is ADHD is there and you have got associations. While in differential diagnosis, learning difficulty, yes. LD can manifest like inattention. So we need to be compare and contrasting ADHD and select what the diagnosis is. Autism spectrum disorder, I was talking again and again. MR should not be the right term to use. Intellectual disability is nowadays the term which is used properly in this case. Movement disorders, because the children, because of the movement, they may be wrongly labeled as ADHD, and we have to be careful about it. I was discussing about epilepsy. I was discussing hyperthyroidism. Hyperthyroid children tend to be hyperactive and they have got a different presentation. And very importantly, drugs like theophylline, salbutamol, a child who is given a higher doses of or a repeated doses of any anti-asthma management medicines, and the child may manifest for a short duration, like hyperactive, irritable child, and you have to be careful. Again, a child who is not, he is given anti-epileptic drugs, but sometimes the child may be having a side effect or adverse effect of the drug and may manifest as ADHD. And I was discussing in adolescence, always remember substance abuse is another cause for ADHD. I'm going to, because lack of time, we have to complete everything and I have to listen. I'm very much keen to listen to the other two guys. I'm going to stop with the discussion of complications over here. Why? Again, that is one more thing which should be doing, assessing while our complete diagnostic. So academic problems, talk with the teachers, get the child's classroom notebooks, look at his homework, look at his handwriting, and you may require a lot of things to correct on these things. And that is very important. Don't only look at ADHD. Don't go for a label. Go for the complete child. For the complete child, this child, because of he's a good child at his heart, but he cannot sit tight. His attention is poor, so he may not be a good part in playing. So uske dost usko peer rejection is common with these kids. Socially, the child is not accepted. Unfortunately, ADHD, especially adolescent ADHD, or they go into the adulthood, they'll end up into the criminal tendencies are much more with these kids. They are good people at their actually their IQ may be good, but their performance is not. What is going to happen? They're going to go into the inferiority complex, and we need to be working on that. And lastly, obviously, such child is not accepted very well with the family. So the whole family is disturbed. Parents of child, tu mein hote rehte hai, mother and father and child, everybody is in a soup, and the whole family is disturbed. So we need to be looking at these ADHD complications also. And all these things together, right from screening up to this. So as an algorithm to remember for the day, you have got a suspicion either from the parents or from the teachers. Please do not neglect it. Accept it at its verbatim. Go ahead. Screen the child with the basic screening interview. Give time for the parents, give time for the child to talk about it. Then go for the diagnostic tools as standard as question is, along with physical examination, along with rest of the thing. Then look for the assessments. Go in detail assessment, not only ADHD, along with IQ and smaller kid, along with the developmental assessment as well, and looking at the complications, comorbidities, and all that. And if required, there and there only you go for investigation. Investigation carry not a big meaning in that. From assessment, you can actually start for the management protocol for this kid. So all that becomes the first part of ADHD management. And I'm really interested how this diagnostic part is taken care by my learned colleagues right now. So I think I'll stop over here, and I'd like to answer the questions when the time permits, probably at the end of the session. Thank you all. Thank you all for patiently, and thank you again, the Kepler people, for inviting me for this. I end with this quote, which I like. You are all listening to me patiently. So I'm very sure you are all not ADHD. And I'll stop over here. Thank you.
Okay, Dr. Sunil, that is a very, very nice presentation, and you have made that criteria simplified. Especially, I have seen that many of the doctors are finding it difficult to remember all the criteria which are being discussed in the DSM-5. So you have made it simple, and along with that, the other additional diagnostic clues also you have done, and the algorithmic approach was also very good. I think before orals, shall we have all the discussions, all the presentations, and then we'll have a discussion. That may be
I
the best.
think it will complete, and so that we all think can put together. That's what I personally.
Yes. Now, Dr. Deepak, are you ready there?
Yeah, I'm there, Dr. Kanju. Thank you.
Okay, that's good. Dr. Deepak Gupta, he's MD DNB CAP, IOP from King's College London. He is actually the Child and Adolescent Psychiatrist, Founder Director, Center for Child and Adolescent Wellbeing, Senior Consultancy, Gangaram Hospital. So definitely, I think the experience of Dr. Deepak Gupta would be an eye-opener for all the attendees who are trying to manage children with ADHD. He'll be talking on the behavior and other non-pharmacological interventions, which definitely, because the non-pharmacological interventions are very, very important in the management, and many times pediatricians, pediatric neurologists, and psychiatrists find it difficult to counsel these parents, because assessing itself will take time. Then again, counseling may take another long time. So I think Dr. Deepak will give a brief outline of this behavioral and other non-pharmacological interventions. Dr. Deepak, please.
Yeah. Am I audible? My slides are visible? Yeah.
Yes.
First of all, good evening, everyone, and thanks to Dr. Kunju, and thanks to Kepler for organizing this talk, and thanks to Dr. Sunil for giving his initial presentation. I'll be talking about the behavioral and other non-pharmacological interventions. Yeah. So already it has been talked about. Just a few lines to start with. The ADHD, attention deficit hyperactivity disorder, as Dr. Sunil already mentioned, one of the most common neurodevelopmental disorders. And taking it forward, medication and non-pharmacological treatments are evidence-based intervention for ADHD in various age groups. There's a lot of evidence which has come up for the various interventions, pharmacological and non-pharmacological. And my presentation will elaborate on the behavioral and other non-pharmacological interventions that have been studied in ADHD. And after me, the learned speaker will talk about the pharmacological intervention. Now, these are the various non-pharmacological interventions: psychoeducation, environmental modification, parent training, academic support, school licensing, individual and family therapy sessions, lifestyle modification, diet, physical exercise, supplements, neurofeedback, cognitive training, and neuromodulation. So there are n number of non-pharmacological interventions are there which is available, and there are others also are there which comes under part of the complementary and alternative interventions, but I have highlighted some of the most important ones. Now, coming to psychoeducation, according to me, this is the most important part. This is the most important intervention which is required. Psychoeducation should be carried over 2 to 3 sessions and should be tailored for a given child and the family. We should not be in a hurry. Educating the family, what is ADHD, how ADHD is impacting the child, what are the various impacts it can cause, and we simultaneously, we should respect the various socio-cultural factors. Every family is different. We have to understand that every family has their own prejudices, own attitudes, own belief system. Along with that, we have to make sure we're respecting that, we have to educate them. The clinician may involve other significant family members during these sessions, including the parents, grandparents, siblings, as required. Because if you're able to involve and educate the family members who are involved in the care of the child, you're able to get better results. How you start? You begin by asking the patient and his family regarding their own understanding of symptoms, their causation, and the beliefs regarding treatments. What do they know? What is their belief? Some people may say, no, he's just doing it. He just want to trouble us. Some may say, oh, no. He can do it. He's just doing a drama. Some people say, no, we don't know why he does it. He's such a bright kid. But sometimes I don't know what happens to him. So understanding the belief system is important. And then we as a clinician presenting the diagnosis as a brain disorder, neurodevelopment disorder with both genetic and environmental influences. Briefly present the psychosocial factors that can potentially influence the course and outcome of the disorder. How inconsistent parenting, family discord can lead to defiance, poor compliance, can cause emotional difficulties, how those things are important to be addressed. Never ever blame the parents. That's very, very important. Never ever blame them. Never say it's because of you, you got the ADHD. It's because of you, the child has ADHD. Never ever blame the parents. Yes, parents can have also ADHD. They can be a very high genetic loading. The father may have, or other family members may have. But yes, we don't have to directly blame them. The clinician must, as far as possible, address the guilt and blame of the child, especially I've seen in the mothers. Some days they believe that because of them, because of her, the child has got ADHD, or the other family members blame. So educating them addressing the misconceptions regarding ADHD, giving the information about prevalence. It is not your child. In a class of 30 to 40, at least 2 to 3 children have ADHD. ADHD is present across the world. So giving them the prevalence, telling them, discussing the evidence, benefits, and possible risk and probable duration of the available treatment. So this is it's the type of ADHD, the level of ADHD, the severity, what all interventions are possible, and then involving the family members in a collaborative approach, in a collaborative approach, so that they are able to take a collaborative decision with you. My experience says, and there are a lot of studies which says, if they educate them 95 to 98% times, the main reason for dropout is lack of psychoeducation. So if you want a good compliance, if you want them to stick to the treatment, because we know it's not one-day affair, then please spend time on psychoeducation. And especially when you're working with adolescent, educate the adolescent, build a good rapport with the adolescent, understand his perspective, spend time with the adolescent alone, and then start the treatment. So that's one of the first one. Now coming to the second one, environmental modification. Environmental modification includes changes made in the environment in one or preferably more settings to either decrease the symptom manifestation or, importantly, decrease the impact of the symptoms. Such modifications should help enhance the performance and functioning of the child. What are those environmental modifications? They look simple, small things, but they're very, very important. The daily routines, such as those related to getting up and getting ready. So creating a schedule, creating a routine, a structure on returning from school, meal times and bedtime must be made regular and predictable. The child must be informed in advance of any changes in the schedule, as well as given reminders during transition. Preparing in advance, allotting a fixed place for almost everything in the house, and particularly for belonging of the patient. The more you make the thing structured, organized, labeled, the more you feel the child will have less difficulty. Using of verbal prompts and visual cues may be necessary for effective implementation. Just giving me visual cues, and that's where you can use technology. Parents can help the child in planning and managing their time through use of daily and weekly planners, taking planners in prominent places, such as in bedroom or nearby the study table. So these environmental modifications can help children with ADHD. The effect size has been found to be around 0.5. That means out of 10 children, almost 4 to 5 children has been found to get help by environmental modification. Now coming to the parent training, one of the most important intervention is a parent training, also called as a parent management training or parent management. Different names are given, but yes, it's a parent training. So either it can be done in individual like parents, or it can be done in group parent training, depending on the resources, depending on the facilities available. The aim at imparting skills to the parents that they're able to implement behavioral strategies effectively. Parents must be explicitly told that referral for parent training does not mean that their parenting is faulty. This is very, very important, not to bring guilt to them. You are a good parent, but how can we learn more? How can we understand ADHD better? How can we learn various techniques and strategies to deal ADHD effectively and efficiently? That should be conveyed to them, rather than saying, no, you don't know how to do it. Let me teach you. No. The training should help them in learning strategies for particularly difficult and extraordinary situations that they are facing. And that's where the collaborative approach. We need to empower them. We need to enhance their competency. That is the purpose. The clinician must remember, while dealing with the parents and families, that a parent might himself or herself have ADHD with its resultant attention and organizational difficulties and impulsivity. They themselves have challenges. Parents' own ADHD features may come in the way. They may be having depression and anxiety. That has to be addressed. And because that may hinder the effective implementation of the strategy. It must cover psychoeducation, environmental modification, and effective communication method. What has been seen, the parent management training programs, the effect size is 0.65. Out of 10 parents, 6 to 7 parents show good results. So parent management training is very, very important when we are working with children with ADHD. The important communication skills are 4 C's: clear, specific, short instructions. Clear, specific, short instructions. But please do it. Please, can you just keep your things there? Can you close the bag? and avoid no word in that. So simple, clear, short instruction. Can you please switch on the TV? You know, it's 5 minutes to go to the bedtime. So, and consistency between what is said and done. That's important. And please try to catch them good. For small thing. Wow, you did so well. Wow, you kept all your stuff inside. Very good. For small things, because that appreciation, that will enhance their confidence, that will make them feel good about that. So clear, specific, short instruction, consistency between what is said and done, catching them good, and cut down critical comments by avoiding using the word no, you don't do it, you don't understand, you always keep on making mistakes. Please avoid all those critical comments. So this is the way you can do effective communication skills while doing the part of the parent management training. Now, another thing important is academic support. And Dr. Sunil was talking about, liaising with the school, interacting with the school teachers. So what I always do I have a form I send to the school through parents. And whenever school liaison with me directly, I always email the form to them after taking permission from the parents. And then we are able to work together. And the main thing which has to be emphasized, let's work together to help the child. Let's work together to say how can we do the right strategies for the child's well-being. So adult supervision may help the child, especially when the subjects are boring or mentally demanding tasks such as homework. The parents or teacher may give a simple reminder to the child when he or she goes off task. Such reminder may be verbal or physical or both. Tapping on the shoulder, telling, wow, can you read the 5th question? Wow, can you please, you're doing so well. Can you tell me where are we? So just a small verbal prompt, physical prompt, while studying, minimizing the distraction around, making the child sit away from the traffic or away from the screen, or especially away from the windows. The study table may be in the corner of the room, away from the windows, doors, with only the books which the child is supposed to read at the time. Increasing the stimulation of the material related to task or improve attention through the use of highlighters, using colors to highlight important points. So making it more visually attractive through pictures, through highlighters, through stickies, all those things. With providing the break time in the middle of the lengthy or boring task. The break may be around 5 minutes to 20, this thing every 15-20 minutes or every half an hour, so that they are able, so for them it doesn't become so boring. And the parent may request the child to carry out a household chore also, or fetching water, or just telling them some story for a few minutes or some joke, and then bringing them back to the studies. For some children, extra time to complete work, decreasing workload, giving small assignments, focusing on must-knows also can improve. And it has been seen by providing academic support along with the environmental modification, the effect size is around 0.5. Out of 10 kids, children and adolescents, almost 4 to 5 children gets benefited with it. School listening. Listening with the school be a continual activity I was talking about. Teacher can ask the child to be seated in the front row. In a school, the teacher may ask the child to distribute copies of fetching someone from the other classroom to give them needed break, so that the child is able to channelize his energy, is able to get adequate breaks. The child must be given adequate opportunity to channelize excessive energy by participating in physical sport like cycling, running, swimming, or football, to encourage the child by appreciating on the efforts while minimally using punishment. So again, this has been seen. The working with the school and the teacher support, almost the effect size is 0.5. Out of 10 kids, around 4 to 5 kids do get benefited. So you see how these various interventions can be helpful. Again, the individual and family therapy. In case of older children and adolescents who have benefited from environmental modification and parent training, use of medication, but still have significant impairment, individual therapy should be considered. Along with that, focusing on the social skills in dealing with the peer, time management, problem solving, dealing with and expressing feelings, self-control, and anger management. Family therapy, family work is very, very important, addressing the interpersonal relationship difficulties, substance abuse, and psychopathology in family members, and stress in the family, how to understand ADHD and how to deal with it. Effect size has been 0.69. That means family and individual therapy, out of 10 kids, 10 adolescents, 10 families, it has been found that 6 to 7 families, they do found benefits when the individual and family therapy has been added to it. Now coming to beyond other non-pharmacological, which also comes under complementary and alternative interventions. So The first thing is physical exercises. The physical exercise is especially exercises like which can decrease hyperactivity, improve pro-social behavior, provides consistent routines, better sleep, boosts self-esteem, and minimum 30 minutes of physical activity before homework or school improves attention. Some studies have found effect size almost to 0.6 to 0.7 to 0.8. And yoga meditation improves attention, part of mindfulness, improves self-esteem, and improves school performance. It has been shown that these physical exercises, yoga meditation, improves the good, especially the norepinephrine and dopamine, and which really helps in improving the ADHD symptoms. The diet, yes, overall nutrition, it has been found that Mediterranean diet or the Indian diet, which is avoiding food of high glycemic index, processed food, packaged foods, has been found to helpful. Some studies have found elimination diet of effect of like Feingold diet, avoiding artificial food coloring, artificial flavor salicylates, effect size of 0.2 to 0.4. And along with that, it has been found that especially when you're able to avoid processed food, packaged foods, it really helps. My experience is that all these physical exercise, yoga, meditation, and diet, they all help in mild ADHD. In mild ADHD, I've seen very good results, but in moderate to severe ADHD, I have not seen much results with these interventions. Coming to supplements, yes, as Dr. Sunil was talking about iron, yes, iron supplementation in children with deficiency or low levels, increasing the ferritin to more than 40 to 45 nanogram per ml helps to improve attention span and concentration. And meta-analysis have found no difference in serum iron levels in youth with ADHD, but small to moderate reduction in serum ferritin. And when you address that, improve attention span, concentration improves. So it's worth looking into it. Omega-3 fatty acids. There's a lot of talk about omega-3 fatty acids, supplements, but the important thing is that, and that's my personal experience, 1 to 3 grams per day. And that's what various studies have found. Not 400, 500, 300, no. 1 to 3 grams per day of omega-3 fatty acids. It supports aspects of learning ability, concentration, and coordination. Omega-3 fatty acid supplementation was associated with small to medium improvement in ADHD symptoms in 3 meta-analyses, which has been found, but the effect size was almost 0.2. So it was not a very high effect size, but yes, again, in mild ADHD, mild ADD, it has been helped. L-carnosine supplementation, 400 to 800 milligram per day. I've seen improvements in a lot of children. I've used, what my experience is that 400 to 600 is a good dose. Usually I've not seen much improvement on 800 milligram per day, but usually 400 to 600 is the right dose. Zinc supplementation in children with deficiency or low levels helps to decrease hyperactivity and impulsivity, and same around the dose of, so keeping zinc around 100 or more than 100, it's very helpful. And again, with magnesium supplementation, it decreases hyperactivity, impulsivity on a dose of 100 to 300 milligram or 400 milligram. It improves inattention and better sleep also. Now, coming to the neurofeedback training and cognitive training and neuromodulation. Yes, in neurofeedback, the child can monitor and control their brain activity to directly alter the underlying neural mechanism of cognition and behavior. We have been using computer-based cognitive training at a center. We have used in the past a software called Captain's Log and Play Attention. Now we are using a software in collaboration with Orange Neurosciences from Canada. The name is D-Game and D-Game. And we have just used from the May, and we are almost done with 30 children, and we are seeing promising results. It assesses the underlying cognitive dysfunction and formulates an individualized plan to stimulate specific brain areas and function, again in mild ADHD and mild ADD. A meta-analysis of 5 RCTs exploring the efficacy of neurofeedback, it found a small reduction in attention, but no significant reduction in hyperactivity and impulsivity or overall ADHD symptom. So quite promising, but again more in ADD subtype. One of the new computer game which just came up with Endeavor, the first FDA-approved prescription video game for 8 to 12-year-old, 25 minutes per day, 5 days a week for 4 weeks. It has been launched in USA, but not has come to our country. Let's see how promising it comes. But overall, the effect size is 0.3 to 0.4. Out of 10 kids, 3 to 4 kids show benefits. Now coming to neuromodulation. A lot of studies are coming up and people are talking about that. But yes, majority studies are conducted for adults, limited in children with mixed results. Some studies shows improvement mainly on intention and cognitive measure as compared to hyperactivity. RTMS, not much result. TDC has much more result. The Monarch ETN has got approved, but again, the effect size of all these neuromodulation is around 0.2. Out of 10, only 1 or 2 kids showing effect. So these seems to be promising, maybe the future, but yes, I think we need more studies and more evidence to say that they're working. So in a nutshell, overall, you see a lot of behavioral non-pharmacological intervention can be done, from psychoeducation, environmental modification, parent training, academic support, licensing with the school, therapies, lifestyle modification, supplements, neurofeedback training, and neuromodulation. So all these non-pharmacological intervention should be used, especially at the first line, in starting cases, in mild cases, and if they're not effective, then only we should go for the medication, or in the cases with moderate to severe, we should go for the medication. And we know the medication, the effect size for atomoxetine, non-stimulant, is almost 0.6 to 0.7. My next speaker will be covering that. And for MPH, it's 0.9. So definitely the effect size for medication is very high. To conclude, I will say the behavioral and non-pharmacological management is the mainstay of ADHD management in young children. They can be highly effective, especially when used in combination with medication, or as an alternative for individuals who cannot or do not want to use medication. A lot of adolescents, a lot of parents, they don't want to start medication. And in those cases, again, we have this gamut of non-pharmacological intervention along with behavioral intervention to be used. Further research is required for the effectiveness of dietary intervention, supplements, neuromodulation, and cognitive training in ADHD management. They are promising, but we need more and more intervention. Thank you very much. Thanks for your patient listening. And thank you, Kapler, for giving me this opportunity. Thank you very much.
Okay, thank you, Dr. Deepak Gupta. That was a wonderful presentation. Again, I think we can hear only from a person who has experience in behavioral management of children with ADHD. I think we will go to the next talk also. After that, I think we'll have a discussion. Again, my friend Dr. Debashis Panigra, he will be talking on pharmacotherapeutic options. He has done his fellowship in pediatric neurology. He is the consultant pediatric neurologist in Jagannath Hospital, Sahib Nagar, Bhubaneswar. I think he is a well-known pediatric neurologist, and definitely his approach regarding the management of attention deficit disorder, regarding the pharmacotherapeutic options, he'll be very, hope he'll be elaborating the pharmacological aspects of various drugs also. Dr. Debashis, please start your presentation. Debashis, please start sharing your slides. Dr. Debashis, please share your...
I think it's dropped out, Dr. Kanju. I can't see him.
I think what has happened. Anyway, I think please contact him. By the time he joins, we will have a short discussion on the topics that was being covered. I think people have a lot of things to ask about both the diagnostic aspects as well as the non-pharmacological management. Dr. Suneet Godbole and Dr. Deepak is there. I think let me see whether some questions are there in the chat box. Chris talk. So that is the comment only. How long, how in a practical situation, Dr. Deepak, the counseling aspect, the acceptance by parents and regarding the involvement of teachers, how do you involve these two people together, both the parents and
teachers? What is my experience is that usually the parents bring the child or adolescent. So at that go, building a good rapport with the parents, and then telling them that your inputs are very, very important. And your collaboration and your working together will get us more success. Because a lot of time parents doesn't take out time for therapy, counseling. They don't want to get involved. They say, okay, just work with my teenager, or work with the child. So telling them that your involvement is very, very important. So bringing them into that collaboration. And then with the school, as I told you in my presentation, I have a form. I send to the school that form. And then I tell them that if they're able to fill that form, and then I can send certain guidelines for the school, how they have to behave, how they have to interact with the child, how they have to manage the child in the classroom. In that way, we are able to manage that. So that is where I am able to involve the parents also and the teachers also. So in that way, we are able to work collectively with the both of them.
Does the teachers accept the diagnosis of ADHD, and do they?
Yeah, sometimes it is tough, Dr. Kanju. Sometimes it is quite tough because a lot of time teachers may not say. They may say it's the child is doing deliberately, but once it comes with the official report, with a proper assessment, with your proper letter, with your credentials, and it goes to them. Yes, I've seen now teachers have started accepting in the bigger cities. So so once you do it properly, and then you said yes, work on it. So a lot of times I send to them. Sometimes they accept it, sometimes they don't accept it. But I tell to the parents, don't worry, let's keep on working with it. But yes, acceptance can be a little challenge for the teachers to accept. And in those cases, we have directly worked with the headmistress or the school principal and have addressed it directly to them. And then we got some support, and then we were able to take it forward. But that can be a very big challenge, a very important point.
Okay, thank you. Dr. Sunil.
Sorry, sir, my
Hello.
hello.
Devashish.
Yes, sir. Yes, sir. My internet Wi-Fi got disconnected. Now I'm connected through phone.
Okay, yeah, I think you can share your
Yeah,
presentation.
sir. I will share the screen, but it's saying the host disabled participant screen sharing.
Make it brief so that.
Okay. I will be in 15 minutes, sir. Not more than that. I'm not able to share the screen. It's saying host disabled participant screen sharing. उमा शंकर जी,
आप उनको host enable करो ना.
Yes, doctor. Few minutes, doctor. I'll call it. I'll call them, doctor. I'll call the motion.
So you can share right now, sir. You can share right now.
Oh, now I can share. Okay. So you can see my screen, no?
Now you can.
Yes. So thank you, Kunju sir. Thank you, Vibronica, for giving me this opportunity. And I really sorry for this technical glitch due to internet issues. So today I've been asked to talk on pharmacotherapeutics in ADHD. So as you know, the prevalence of ADHD is quite high in India also. A study from Coimbatore has shown the prevalence to be 11.3% and with a male preponderance. But in spite of this high percentage of children with ADHD, studies have shown that those with children who are prescribed with medication, as high as 83.3% discontinued taking their medication within the first month. And reason commonly cited by the parents are due to side effect, lack of effectiveness, problems at the hospital, they can't go many times, fear that the child may become addicted to the drugs, among many others. This is very commonly that what we see from the parent. So why this happened? So first we need to understand what is the expectation from treatment with pharmacotherapy or with non-pharmacological intervention also in ADHD. So are you going to cure ADHD with medication? Then the answer is no. And the parent usually don't understand this when you write our prescription. They feel that when we write our prescription, the child is going to take some days and all the symptoms are going to go. But that usually does not happen. That's why sometimes they discontinue the medication. So what is the aim or what is the expectation from treatment? So basically it's as good as it gets. This was a big, nice movie, soft romantic movie. Jack Nicholson and Helen Hunt both got Academy Award for it. Nothing to do with ADHD, but the protagonist here has OCD. And meeting this girl falling in love makes him better. So basically this treatment also in ADHD is like that. What we want to make the child as good as better he can be. If you go and see the definition, DSM-5 definition of ADHD, you know that the word impairment has been giving a lot of importance. Not just mere presence of symptoms does not make a diagnosis of ADHD. You have to show impairment in 2 or more settings. So the basic aim of pharmacotherapy or any intervention is to decrease this impairment, and this impairment bothers the parent most. The child is hyperactive in home, they don't bother about it. When the child go to school and the teacher tells 4 times this, "Aapka bachcha class mein baithta nahi hai, dusron ko disturb karta hai," then they become concerned and come to you. So the basic aim is to decrease this impairment, decrease the symptoms, so that the child can better function in the society. So this needs to be understood. So this I found when I was searching. So it's a very nice and cute note. Here the child has told shut up to his teacher, and after that he understands that, and this handwriting is very typical of ADHD. They don't write good handwriting many times. So I'm sorry, Mrs. Miller, that I have told you shut up. I really didn't mean it. And the reason that I talk so much, because everything I think in my head bursts out of my mouth. It's a bad habit, but I'm not a bad kid, and I'll try to be better. So this is the truth of ADHD. They are not bad kids, they are good kids, but they just can't control their symptoms, can't control their impulse. And medication, a small dose of medication before going to school can really help this kid. So does ADHD medication work? Many times when patients are referred to us by pediatrician or primary physician, and we ask कि चलो आपको ADHD है, हम लोग medication start करेंगे. Then they go back and ask कि the doctor wants to start my child on medication. So will it work? So there is sufficient evidence to tell that medication works in ADHD. Not only for long term, not only for short term improving the course and the symptoms, but also in a long term basis. So there are a lot of studies, 300, 400 studies are published every year, which show that ADHD medication dramatically reduces the core symptoms of ADHD. Adults who are diagnosed with ADHD as a children, then second part is that adults who are diagnosed with ADHD as children have a greater risk of experiencing difficulties in major spheres of adult life like job performance, personal life, social relations, sexual activity. Then they commonly indulge in illegal activities, substance abuse. And studies have shown that the adults who are diagnosed with ADHD as children and who took medication are always better than those who did not took medication when they were children. And secondly, and this is one more thing, is that children with ADHD, that areas of the brain that are smaller, and when these children take medication as a younger child, when they become adult, these areas, the size of the areas, studies have shown that the size of the areas are also increased. So these are the different help of medication. Therefore, the answer is that medication definitely works in scenario. So this was a meta-analysis which was published in Lancet Psychiatry in 2018, and it is comprised of 133 studies, and they have shown that all the medications in what we are going to discuss are effective in ADHD. It includes methylphenidate, all amphetamine, all non-stimulant medication, and methylphenidate, as sir has already told, the size of methylphenidate is 0.9. So stimulant and methylphenidate is the medication which is most effective in treating children with attention deficit hyperactive disorder. So as Sunil sir was indicating that these are the areas of the brain that are more commonly affected in the ADHD children, like your prefrontal cortex, which is helps in planning and organization, your frontostriatal cerebellar projection that helps in attention, focus, ignoring distraction, and caudate nucleus helps in learning and memory. So function MRI studies have shown that these areas are small in children with ADHD, and when they take medication and grow up to the adult life, there is increase in the size of these areas. So all this conclude that ADHD medications are definitely effective. So when indicated, definitely we did not shy away from treating these children with medication. Now, this is important. So contrary to the general belief that parents believe that when my child will grow older, this ADHD will go away. But that's not always true. 80% of the affected children, symptom of ADHD persists into adolescent and adulthood. Though as the age grows, the hyperactivity and impulsive symptom can come down, but the inattention, disorganization, relationship difficulty persist. There can be other psychiatric comorbidities like depression and other disorder will come along. So it's not going on its own. If not properly treated, individual across age span are at risk of multiple things. With a combination of medication and psychosocial and behavioral intervention, most children's symptoms can be ameliorated and he can have a better life. Therefore, it's important to treat ADHD. Now, coming to different medications that we have in our kitty. One, they are basically divided into two groups. One is your stimulant and is your non-stimulant. Stimulant is methylphenidate and amphetamine. Methylphenidate is more commonly used. And in non-stimulant, this is the alpha-2 agonist, clonidine and guaifenesin, and your selective norepinephrine reuptake inhibitor like atomoxetine. These are the drugs that are commonly used. So this was the clinical practice guideline that was published in American Academy of Psychiatry, published by American Academy of Psychiatry in 2019. And they have recommended that in children who are between 6 to 18 years of age, approved medication are the first line of treatment, and the second line of the treatment are your evidence-based parent or teacher-administered behavioral therapy are the second line of treatment, and preferably you can use the both. Again, you can diagnose ADHD as early as 4 years of age. So between 4 to 6 years of age, the same criteria can be used, but behavioral and non-pharmacological intervention are described as a first line of treatment in 4 to 6 years of age. This is why, because most of the medication that we are talking like clonidine or methylphenidate are FDA approved above 6 years of age. So 4 to 6 years of age, behavioral intervention will be the first line treatment, and above 6 years of age, it's recommended that medication are the first line of treatment. Again, I will tell here that as Sarah was highlighting, before 4 years of age, ADHD diagnosis is difficult. It's a school age diagnosis. That is after 4 years of age. So any child who comes with a diagnosis of ADHD is less than 4 years of age is unlikely to be pure ADHD. It's most likely to be autism spectrum disorder who has marked hyperactivity, because many of the hyperactivity symptoms. Why it is important to differentiate? So what we are discussing now is a treatment of ADHD, not ASD with ADHD. When ADHD is a comorbidity with autism, this medication may not work that well. The side effects can be more. So it has to be treated in a different approach. So that very important to differentiate between ASD with hyperactivity and pure ADHD in a child, mainly in smaller children. So coming to medication, again, the stimulants are the first line of medication because they are more effective. Methylphenidate is the drug that most commonly used. The selective norepinephrine reuptake inhibitor like atomoxetine are the second line, and alpha-adrenergic like guaifenesin and clonidine are the second line or a adjunctive treatment. So coming to stimulant, these are the most common type of medication used in ADHD. This sounds very unusual because the child is already hyper, so why you are using stimulant, but it always helps. It works by decreasing the chemicals in brain like dopamine and norepinephrine, which plays an essential role in thinking and attention. And under medical supervision, stimulant medication are always considered safe. Now, two types of preparation are available, as you all know, a sustained release preparation as well as short-acting preparations are available, immediate release preparation. Immediate release preparation starts working early, but the effects last for 3 to 5 days, 3 to 5 hours only. And for a sustained release preparation, this starts working little late, but the effect can last up to, in some cases, even up to 12 hours, generally between 6 to 8 hours, and some preparation even up to 12 hours. Always start with a very low dose, maybe 2.5 milligram or 5 milligram per day, then gradually increase the dose. Dose is not very clear. Many people say that less than 25 kg, the maximum dose is 35 or 40 milligram, and more than 25 kg, the more is 60 milligram. Start with low dose and gradually increase the dose every 3 to 7 days. So this is how we use methylphenidate. The optimal dose of ADHD, this is important to remember that the optimal dose does not depend only on the age, weight, gender, or severity of symptoms. It is different factors like how efficiently the medication is absorbed from the gastrointestinal tract, how effectively the medication is metabolized, and how efficiently the medication crosses the blood-brain barrier. Therefore, there is individual variability. The same dose will be working very good for a child of same age and weight, but the same dose will show a lot of side effect in another child. This is very common, and all of us have observed this. So this is because this dosing and the effect depends upon multiple factors. Therefore, the American Academy of Pediatrics recommends that always the child should be followed up closely and dose adjustment should be done at least once a year to achieve the symptom management. Now, frequency of dosing is not that straightforward. A child with predominantly inattentive type of ADHD may need medication only on school days because he needs focus in the class. Who has difficulty with peer relationship may need medication every day. A child who participates in after-school sports or activities on certain days of week may require longer-acting preparation and more frequent dosing on the dose. So optimal dose is not a fixed dose. For this weight, this much is optimal. The optimal dose is at where we get the target outcome with minimal side effect. So we tend to achieve what we want to achieve, and we have to decide what we want to achieve. That's very important. If the child is predominantly problem in the school, then you have to give it 1 or 2 hours before going to the school. Or it's not because what is the most bothering symptom, what is the problem of the child, that needs to be kept in mind when you are dosing or when you are the timing of the medication. So that's very important. And this last line is important because optimal dose, you can start with low, gradually increase, see a dose where this effect is most and the child don't have major side effect. So common adverse effect with stimulants will be decreased appetite. That's most common. Weight loss. Tics is another stimulant, usually precipitates tics. So very careful. Take a history whether the child has tics, then better to avoid stimulant. And many times we have seen we start stimulant medication, the child develops very severe tics. Then you have to stop the medication or change to another medication. Because of decreased appetite, growth failure can be there. And some studies have shown that methylphenidate or stimulant can cause growth failure, but many studies have again shown though there can be a transient decrease in growth, but the adult height is usually not affected. Adult growth, this adult height exercise not usually affected by methylphenidate. Then some children get dizziness, insomnia, decrease in sleep is very common in stimulant. Therefore, many times we prescribe the medication in the morning before going to school. The child takes the medication and goes to school, and we avoid nighttime doses. Paradoxically, some children, it helps in sleep also because they say this brain is running around, and when the brain becomes calm, the child sleeps better. Then mood levelity, there can be rebound when the dose is decreasing or the effect of the dose is decreasing. There can be a rebound hyperactivity and rarely psychosis. Cardiac side effects are described. Sudden cardiac death has been also been described with methylphenidate. Therefore, one with pre-existing cardiac disease, it is contraindicated, and one should be very cautiously using in that scenario. Other drugs that are effective are atomoxetine or non-stimulant. The duration of action is around 10 to 12 hours. They start with a low dose like a 0.5 milligram per kg per day. and gradually increase to 1.2 milligram per kg per day. And this is the maximum dose. Again, this is a very good medication. If stimulant, there is a contraindication to stimulant, or there is a side effect to stimulant that cannot be managed, then atomoxetine is the alternative. It causes a little drowsiness and dizziness and all those things. Therefore, one should be careful using it. Maybe nighttime dosing will be helpful in this scenario. Other drugs that are effective are clonidine. Clonidine is an alpha-2 agonist. This has been approved in 6 to 17-year children. The dose we can start, the 100 microgram tablets are available. One can start with a low dose like a 25 or 50 microgram per day and gradually increase from 0.1 to 0.4 or 0.3 or 0.4 milligram per day. So that's how it dosing. Again, it can cause drowsiness and sleepiness. Therefore, very difficult if you are giving it before school. The child may doze up in the school, and rebound hypotension and rebound hypertension are some of the described side effects with clonidine. So when you are stopping clonidine, one should be careful. So how to the main point in medical management or medication managing with medication is that just writing the medication is not going to help. There are a lot of follow-up and lot of minute or fine-tuning is required when you are treating a child with medication. Sometimes what happens when you give medication, the child becomes very wet, racy, irritable. Then you know that this dose is probably high. After 1 hour of giving the medication, the child is, that means that the dose is high. And if after 4 to 5 hours of giving this medication, the child is again becoming very hyperactive and irritable, maybe this is a rebound effect when the dose is decreasing. So one has to understand how this is working. So when the dose is decreasing, adding a small dose may be helpful in that scenario. Now, coming to stimulant, long-acting and short-acting preparations are available. As I was told, sometimes long-acting stimulant wear up too early in the afternoon. I start giving a 20 milligram of methylphenidate in the morning, and the evening the child is going to tuition. I gave a morning dose at 7 a.m. So by evening 6, 7 p.m. the effect has decreased. So maybe it will be difficult for him in the evening. So we need to adjust short-acting dose by a immediate acting preparation in the evening, so that it does not hamper the sleep also, and he can be better managed in the evening. Again, long-acting stimulant may kick too slow and may need a small dose short-acting booster to be taken along with a long-acting. If you need an immediate effect, then a short-acting booster can be combined with it. So this is how fine-tuning of medication needs to be done. So one has to understand that higher doses are not always effective, and dose and timing needs to be very carefully adjusted in every individual. And the children and adults vary a lot in how fast they absorb and how fast they excrete a particular medication. So advantages of extended release medication is that it provides sustained medication level throughout the day, minimizes these ups and downs, no midway dose required, eliminating the trips to school, reduces the stigma, enhances the patient compliance. So if the medication is not working, I have started methylphenidate to the child, gone to 20, 30, and it's not working, then we need to see the dose. Maybe I'm giving a lower dose, so I increase the dose. And if this medication is not working, let's try a separate medication like by atomoxetine or a clonidine in this scenario, and never forget about comorbidities. So sometimes coexisting comorbidities like depression, anxiety, sleep problems, stress, or any medical problem may be complicating the issue. So when it is not working, go back and think why it's not working, what we are missing, and we can come up with a new plan in that scenario. So when we know the medication is working, if the medicine is working, the child will have better focus in this class, better focus in home, less impulsivity, there will be improved mood, greater attention to detail, less mistakes in the classroom, less mistake in the copy. He will not forget things in school. He will bring back the objects, better memory, better organization, the sleep will be better. So if all these things are happening, then we know that our medication is working in this scenario. So if we are facing problem with the medication, one need to look at wrong medication. As I was describing, suppose you are giving methylphenidate and this child has tics, then the tics may get worsened. So in that scenario, we need to change the medication. Second, generic versus brand. In medication, in this, there has been shown that brand versus generic, there can be a difference of as high as 20% effectivity in these two. So when changing from one to another, one should be careful. If the child is on a brand medication and change to generic medication and the child is deteriorating, so or vice versa, one can look at it. Then coming to wrong dose. Definitely, as I have told you, this medication does not, this mostly stimulant medication does not, the same dose can be effective for a child and the same dose can be very high or a lot of side effects for another child, because it does not just depend upon the age or weight of the child, other factors. Therefore, one need to titrate the dose very important. Then wrong timing. You need to time your medication very properly, because what you need to understand, what is the major impairment or major problem in the child, and you target the medication so that he can be better during that period. Then again, interaction, these are alkaline drugs, so one should avoid taking a strong acidic like vitamin C, etc., at least 1 hour before taking this medication. Interaction with caffeine can be there. Both caffeine and stimulant medication, if taken together, it can bring irritation and more effects of the more side effects. So all these things has to be kept in mind when writing medication. Then how long you need to continue the medication? There is no clear-cut answer to this thing. This was a beautiful paper that was published in American Journal of Psychiatry in 2019, and they have concluded that continued treatment with methylphenidate remains effective after long-term use. Some individual patient may, however, be withdrawn from methylphenidate without deterioration. This finding support guideline recommendation that patient be assessed periodically to determine whether there is a continued need of methylphenidate treatment or not. And tachyphylaxis is known to occur in methylphenidate, and some children may become tolerant to the drug as time progresses. Coming to just one more slide on nutrient, sir has already touched upon this. So omega-3 fatty acid is very commonly used. I also put this slide to emphasize that low dose are not effective. Maximum studies have shown that in children, the dose should be mostly more than 1000 milligram, and in adolescent, it should be around 2000 milligram. So, and this EPA-DHA ratios have been also stored in studies that at least a EPA-DHA ratio of 1.5 to 2:1 should be maintained in this preparation. Some studies have also even advocated a very high EPA-DHA ratio of 5:1 to be effective in ADHD, but at least a ratio of 1.5 to 2:1 is very important. Phosphatidylserine is a new molecule, is available in Indian market now. So some studies have shown that this is effective in ADHD. Vitamin D deficiency is very common in children, so supplementation will help. So as I was telling, ferritin level has been shown to be little low in children with ADHD. So where we find this iron supplement can be helpful. Magnesium, though it directly does not help to improve inattention, but it decreases impulsivity and hyperactivity. So a dosing of 100 to 300 milligram, 400 milligram per day can be very helpful in scenario. So coming to my last slide, medication are definitely an important part and mainstay of treatment in children with ADHD above 6 years. Stimulants are the first line of medication if no contraindication. No routine ECG need not be done in all children before starting methylphenidate, but definitely a history of pre-existing heart disease should be taken. And combination may be tried, like methylphenidate with clonidine is a good combination and can be tried, but side effects can be higher. Remember, pills don't teach the skills. Therefore, only medication may not be always sufficient in children. Therefore, medication should be combined with other non-pharmacological intervention like psychoeducation, behavioral intervention, and all this intervention that has been highlighted. And last line is very important. Just prescribing is not going to help. If you are not going to do a regular follow-up, not keeping in touch with the parent, not able to address the concerns about the medication of the parent, about the side effect, about the effect, and fine-tune and titrate the medication properly, then this most likely going to fail, and patient is not going to continue for a longer period of time. So all these things should be kept in mind. This is a nutshell about medications in ADHD. And one more thing I will just last line I will say, ki when it is associated with ASD with ADHD, the medication may not be that effective and side effect can be more in that scenario. So one need to differentiate between the two. That's very, very important. So thank you for your patient listening.
Thank you, Dr. Debashish. I think yeah, he has extensively covered the pharmacotherapic aspects and how the drugs to be initiated, continued, and how to be followed up. I think it's a long session, and if some comments from others, we can do it. Any questions or comments? I think you can put it in the chat box if you cannot open your microphone. Any questions or any comments? I think in that case, we will conclude the session. It's back to
Sir, excuse me.
Okay.
Before conclusion, there is one question. How will the management be different for a 10-year-old with ASD and ADHD?
I'll just add a comment on that part, and then we will, I think the other experts will. First thing is we have to be really differentiating these things very carefully, because the management actually it's 180-degree turn in both the things. Because ADHD, as we say, talkative child, autism, less talkative child. ADHD, the hyperactivity has a purpose. Autism, the hyperactivity is not with that big a purpose. And not only that, as we are aware, ADHD, as Dr. Debashish rightly pointed, Dr. Deepak would also say that effect size is very good with the drugs. With autism, it is not so. Whatever drugs you do, only 2 drugs which are approved in autism, either risperidone or aripiprazole, are they having the same effect size? It is not so. So when it is we have to be really clear so that the prognostication can be decided. And my personal experiences, as Dr. Debashish rightly said, it really creates problem in autism. This methylphenidate may not work the way it should work in ADHD. ADHD it works well, but in autism it may even create some bizarre issues at the same time.
There is one more question from Dr. Swati Gupta. Is there any role for L-carnosine?
We have already, I have emphasized, yes, L-carnosine do works. And I told that, yes, I've seen results, and that's what my colleagues will agree. It's mostly in the mild ADHD or subsyndromal ADHD features, mild ADD. That's where I've seen L-carnosine working, usually starting with 100 milligram per day to 100, 200 milligram per day to going up to 400 to 600 milligram per day. Different companies have different compositions. Are there? That's what it works on. And it is working on the GABA system. And yes, L-carnosine does work in some population subset. And I've got good results in that population, but not in moderate to severe ADHD.
Yeah.
And sometimes this supplement can also decrease the dose of stimulant. That's what studies have shown. So if we add stimulant and all this with stimulant, maybe we can manage with a little lower dose of stimulant. So that.
Sir, that is all we have.
One more question is there. What is the drug of choice of children with seizure in chart, I think?
Yes, yeah, it has come in chat. Okay, yes.
So, you know, drugs like levetiracetam and brivaracetam is known to cause neuropsychological symptoms in children. So better may be avoided. And drugs like sodium valproate that are mood along anti-epileptic are very good mood stabilizers. So maybe there are more preferably, I generally prefer more to give sodium valproate, lamotrigine, because that is a better effect on mood and behavior compared to maybe phenytoin, maybe levetiracetam or topiramate or something like that. So that's in ADHD maybe.
Thank you very much, sir. Sir, with permission from you all, may I request my colleague to propose
But
vote of
Uma
thanks?
Shankar is very good question which has come at the last moment. I think Dr. Sunil should address this question.
Where is the question? How far should a pediatrician treat such a patient or refer to?
It's a very, very important point. And it is how we can work as a team and how the
Absolutely.
multiple specialties have to work together. I think, and I'll request Dr. Sunil to address this,
I
please.
think pediatrician has to be the key person in the whole process. It
Yes.
should not be just a refer to a developmental pediatrician and chhod diya. It should not happen because day in day out the pediatrician is saying. For example, if the child is on methylphenidate, while starting this methylphenidate, when we write the prescription, the first thing, as the doctor I think we have mentioned, that the parent goes to the pediatrician. And यहाँ पे the pediatrician should give that confidence. Yes, this drug works and I am there. Pediatrician is there to monitor the side effects. So that is the best combination to work on, for example, medication part. Similarly, the tendency of the pediatricians in that busy practice that ये बाद में देखा जाएगा may delay the management at a later time. So I request the pediatrician population over here that you are the best people to pick up it at a very early stage, and then you are the best person to maintain the prognostic follow-up for these kids. So the follow-up, it may not be the developmental pediatrician's job, whether not, it should be the pediatrician's job. Another thing is I have seen that the schools also, they're glued to the pediatrician much easier than the super specialist or developmental pediatrician or even neurologist. So again, that combination, the therapist, the teacher, the parent, and everybody can come together, and the pediatrician is the glue. So one more thing that they can do, the early screening, the interview can be done by the pediatricians, and the pediatrician can do a wonderful job in this part.
Sir, one more question has come. Any dietary changes recommended for ADHD children?
As I already mentioned about that, yes, it has been seen in some children. The effect size is not very high. Again, 0.2 to 0.3, 0.2 to 0.3 has been found out. In some children, it works, especially in smaller children, it works very well. I've seen in my own experience also with a population of 3 to 6 year old, 3 to 5 year old, it works far better. But yes, and then maintaining a diary, removing the processed and packaged foods, removing the sugary products, and then see what's the impact. But along with that is that it is a lot of time, it is not sustainable sometimes. So we need to keep a dietary change and maintain a diary and then see how much improvement is happening. It may work in some children very well. It may not work very well in other children. So that should be child to child. But yes,
it should be adjunct. It cannot replace the behavioral therapy and the medication.
So you can start with the dietary along with behavior interventions.
Absolutely.
And yes, and especially in the mild cases, it works very well. And smaller children, it works very well.
And to maintain the diet, it should be the family diet that should be managed and not the child's diet. पापा उसके सामने पिज्जा खा रहे और बच्चे को बोल रहे आपको ये नहीं खाना, ये नहीं होने वाला.
Yeah. So we need to make sure that the whole family is supportive. If we are cutting down the sugar, if we're cutting down the sugar things, processed foods, if we're cutting down the sugary drinks and all, make sure that everyone, otherwise the child will become more defiant and the non-compliant and more irritable.
Let's say also for management of neurodevelopment, family should be on the same page, even for reinforcers and everything. Otherwise, it's very difficult to manage.
Good resource to, there is some website called Additude, ADDITUD. It's good enough for the parents to understand.
Okay.
Now, may I request my colleague, Mr. Douglas, to propose vote of thanks. Mr. Douglas.
Yes, sir. Good evening to everyone. I thank the speaker, the director of Chiranjeev Child Diet, and Developmental Center, the HOD of Small Steps Morris Autism and Child Development Center, Dr. Sunil Godbole, MD, for sharing his wonderful experience in clinical practices, practice guidelines, diagnosis, screeners, and tests. Thank you so much, Doctor, for your wonderful dedication.
Thank you.
I thank our another speaker, Dr. Deepak Gupta, MD, DNB, DCAP, IOP, King's College, London, child and adolescent psychiatrist, founder and director of CCAW, senior consultant of Sri Gangaram Hospital, Delhi, for sharing his wonderful thoughts on behavioral and other non-pharmacological interventions. Thank you, doctor. Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you, sir. I would also like to thank our Dr. Debashish Panigreki, MD, Fellowship in Pediatric Neurology, Consultant Pediatric Neurologist, Jagannath Hospital, Bhubaneswar, for sharing his awesome views on pharmacotherapeutic options. Thank you so much, Doctor. I thank our chairperson, Professor and Dr. Mohammed Kunju, MD, DM, WHO Fellowship USA, Senior Consultant Pediatric Neurologist, King's Health, Trivandrum, Dean Faculty of Medicine, University of Kerala, Member, American Academy of Neurology, Member, Royal College of Physicians, President of Kerala Association of Neurologists 2019 to 2020, and President IAP Kerala, for accepting to be here as a chairperson in his busy schedule. The moment I called doctor, he said, yes, okay, you can proceed. Thank you, doctor, for your academic interest. Thank you so much. And I thank all the audience for your active participation in this ADHD webinar organized by Vibronica, the division of Kepler Healthcare in the ADHD Awareness Month. Once again, I thank everyone present here and I remind. Thank you for everyone.
Thank you.
Thank you, everyone.
Thank you,
Good
sir.
night. Good night, everyone.
Good night, sir. Thank you, sir.
Okay, good night. Good night. Thank you. Thank you.